Medurstand. Understanding Medicine.
Welcome back. This is Professor Aziz-ur-Rehman, and in my last lecture on hypothyroidism, we discussed etiology, pathogenesis, and the diagnosis of hypothyroidism, and based on various tests, primarily TSH and FT4, we discussed how to make a diagnosis of primary hypothyroidism, secondary hypothyroidism, and subclinical hypothyroidism. And in this lecture, we will be discussing their treatment. In primary hypothyroidism, primarily the problem is the deficiency of thyroxine. So all we need to do is to replace thyroxine. You know, in the body we have T4, which is thyroxine, but we also have T3. So probably, ideally, it would be nice to replace both thyroxine and T3, but many trials have shown that there is no big advantage of replacing both. Thyroxine alone is very adequate, because in the body thyroxine will be converted into T3 also, and this is also very economical. So in our country, we normally replace this thyroxine, though in some cases you can make a case of replacing with thyroxine and T3, which is not available in our country. Then in secondary hypothyroidism, you know, we made a case that the problem is not only thyroxine deficiency, the problem is in the pituitary. The patient is likely to have other hormonal deficiencies, and the most critical of those is actually the steroids. So it is a universal rule that if there is secondary hypothyroidism, before you start thyroxine, you must replace corticosteroids, and at least 7 days into the adrenal replacement therapy, then you should start thyroxine. If you start with thyroxine straight away, there is a possibility that this might push them into adrenal crisis. Why? Because if somebody has deficiency of corticosteroids and thyroxine, a combined deficiency may be actually tolerated better. But if they have deficiency of corticosteroids, that may not be causing any symptom. Because of thyroxine deficiency, there is low BMR. BMR is basal metabolic rate. But after starting thyroxine, BMR will certainly rise, and that would make the deficiency of adrenal hormones more critical, and patient may go into adrenal crisis. So first start replacing steroids, and maybe a week later you add thyroxine. In subclinical hypothyroidism, actually it depends upon, I think we decide the case-to-case basis. I think mostly it is best not to start any medication, just repeat the test after 3 months. And then if the patient is symptomatic or there are some other conditions, treatment may also be started. This will be discussed in one of the slides in this lecture. Now, we have made the diagnosis of hypothyroidism, let's say primary hypothyroidism, then we have to treat them with thyroxine. Thyroxine replacement therapy, TRT. First of all, I'll talk about the standard approach, and then I will talk about the approach in young people and approach in elderly people. So the standard approach is you start with thyroxine. The commonest preparation of thyroxine is 50 mcg, and you could start with 50 mcg or you could start with 100 mcg. I think it is best to start with 50 mcg, and after every 2 weeks you increase it by 50 mcg. To save patient visit, what I do is I ask my patient to start with 1 tablet and ask him or her to increase it to 2 after 2 weeks without going for the test. And then I ask them for after another 2 weeks go for 3 tablets, and then continue it for 6 weeks. So that is the time, or 6 to 8 weeks, and I call them back after 8 weeks and I ask them to bring their fresh TSH. Now, if patient has already become euthyroid, and 3 tablets is usually sufficient dose for most patients, 2 to 3 tablets is usually the dose. So 3 tablets, which is equivalent to 150 microgram. If patient is euthyroid, that would mean his or her TSH will already be normalized. But if TSH is not normal, you accordingly adjust the thyroxine dose. If TSH is still high, you further increase the dose of thyroxine. If TSH has gone below normal range, then you reduce the dose of thyroxine. And then you again repeat the test after 8 weeks. Please note down, we will reassess not earlier than 8 weeks because TSH is a protein and has got long life. Even if patient becomes euthyroid in 2 or 3 weeks, his or her TSH will take about 8 weeks to come to normal range. So I think there is no hurry. It's a lifelong condition, and I think doing TSH after 8 weeks is appropriate. Doing it earlier might actually be unnecessary and will certainly be sometimes confusing. So 8 weeks you keep doing this until you have your TSH normal and FT4 is also within normal limits. And it is required that on 2 consecutive 8 weekly visits, if somebody's TSH and free T4 are within the normal range, then he or she can be declared euthyroid and the same dose has to be continued for life. This is important. You need to explain to the patient that this treatment has to be continued for life. Now, this is a place, if you have not given treatment for those associated conditions, dyslipidemia, anemia, and if you have not given treatment earlier, I think that this is the time that you have those tests again. If patient still has those conditions, then you add therapies for those conditions. Many would have their abnormalities corrected by just thyroxine replacement. Remember, thyroxine is for life with periodic increments. Now, this is thyroxine replacement in young people. Uh, this disease can occur in young people also. Why we go slow in standard treatment? Because people may have underlying heart disease and pushing with the thyroxine too fast may actually precipitate ischemic heart disease. So in young people, since ischemic heart disease or atherosclerosis is very unlikely, so we may start with estimated full dose. Now, depending upon body size, if somebody is 75 kg, my guess would be 100 mcg. If somebody is around 100 kg, my guess would be 150 mcg. So we can start with the estimated full dose and continue with it. And of course, you have to go through with the same process, 8 weekly TSH, and then you adjust the dosage. So this is in young people. Those who are not very young, like myself, patient may have coronary artery disease already known, or they may not have symptoms of coronary artery disease, but they may have underlying coronary artery disease. And remember, this is particularly likely because patients with hypothyroidism may have dyslipidemia also. Okay, so when there is ischemic heart disease or ischemic heart disease is likely or cannot be ruled out, you have the policy of start low and go slow. This is very important in elderly, frail, and those with ischemic heart disease. You start with 25 mcg, and instead of every 2 weeks, you may make the increment after 4 weeks, like increase by 25 mcg every 2 weeks, 3 weeks, 4 weeks, and then make the dose adjustment. So I think you remember, start low with just 25 mcg and go slow. Some would suggest even smaller than 25 mcg, like 12.5 mcg. Ultimate aim would be to make them euthyroid. There are some general principles of thyroxine replacement once daily. It does not have to be given 2 or 3 times a day. It is given once daily on empty stomach. And what is the best time? I think mostly best time is in the morning. And in our culture, people wake up for morning prayer. I tell my patient that when you wake up for your morning prayer, that is the time you take this tablet with 1 glass of water on empty stomach, and you take your breakfast or other stuff 2 hours later. So at least 1 hour empty stomach with glass of water. And it has to be continued for life. Monitor TSH once a year or as appropriate. Now, those who treat diabetes, they know that on every visit we have to monitor their A1C and their sugar, because things do not remain stable in diabetes. But in hypothyroidism, thyroxine is very reliable drug, and once somebody has developed complete destruction of the thyroid gland, so patient is likely to remain stable on the given treatment. So you could do TSH maybe once a year or whenever you suspect. Every time the patient visits you, you must ask if the patient is taking medicine. If patient has stopped taking medicine, then there is no point in doing the TSH. Then you simply ask the patient to restart where he left. Make adjustments as necessary. A patient undergoes some operation, or if there's a trauma, pregnancy, you need to make some adjustments. Now, what is euthyroid dose? Of course, you would guess that euthyroid dose is when your T4 is within normal range. Suppose this arrow gives you the upper and the lower limit of the normal range. So TSH should be within and T4 should be within normal range. Euthyroid. But if you want to go for perfection, then in young people, the approach is that you bring their TSH to the normal range, but in the lower half of the normal range. And you push their T4 to the upper half of the normal range. So both are within the normal range, but free T4 is within the upper half of the normal range and TSH is in the lower half of the normal range. That means you have to keep them slightly physiological hyperthyroid. So this is the philosophy. This has a better prognosis. Now when it comes to elderly, then the approach is slightly different. Because of possibility of underlying coronary artery disease, we don't want to produce hyperthyroid state. So in this case, the approach is slightly different. TSH is kept in the upper half of the normal range, and FT4 is in the lower half of the normal range. Sometimes you will not be able to do this despite your intentions, but this should be actually the approach. Hypothyroidism during pregnancy, since it is a common condition, this affects young people, young women also. So it is a good, there's a good possibility that you see a case of hypothyroidism with pregnancy. So if patient is already a known case, ideally patient should consult the physician and pregnancy should be planned. If patient just turns up with this news that she is now expecting, I think one simple approach is that you add 2 doses per week. Somebody is taking 75 microgram every day and is euthyroid, you can add 275 microgram doses 2 times a week, like maybe on Saturday and Sunday, whatever 2 days. So simply add 2 doses on which patient was already. Or if it is a new case, or if you want to go by trimester specific TSH levels, if you have the facility of going for perfection, then these are the TSH level. For first trimester, TSH should be less than 2.5. In second trimester, TSH should be less than 3, and in the third trimester, it should be less than 3.5 to maintain absolute euthyroid state. In pregnancy, it is particularly important to maintain euthyroid state to ensure that the pregnancy is successful and baby is normal. And be assured, and you also tell your patient that it is absolutely safe. Thyroxine is category A. Thyroxine which we take in the form of tablet is the same thyroxine which our body makes. So it has got no known teratogenic effect. And conceiving and having pregnancy with hypothyroidism carries much more risk than having thyroxine, becoming euthyroid and having a successful pregnancy. Now the approach in secondary hypothyroidism is slightly different, and in this case we first have to replace corticosteroids with prednisolone that is available in our country, and the usual dose is 15 milligram. That is like 3 tablets, 2 tablets in the morning and 1 in the afternoon. And you can also start with the thyroxine 2 weeks after starting corticosteroid. and approximately 100 to 125 mcg. That is the dose. Now you make sure that then you make final adjustment with T4 and TSH and other tests. So these are the starting doses, and then you can make final adjustments. Refractory cases. Now this is important. If somebody is taking thyroxine and his condition is not improving, his lab is not improving, first of all, one established principle is that you check the adherence. I have used the word compliance, but these days we use the word adherence, whether or not patient is taking treatment. So ask every possible question, ask the family, check the drug supply, check the prescription, a patient is actually taking the medicine. So the commonest cause of refractoriness would be that patient is not taking medicine. The problem with the medicine is that they work only when you take them. Then there could be absorption problem. Patient may have some kind of gastritis, or patient may have malabsorption disease. This would be indicated by the GIT symptoms. There could be drug-drug interaction, and that is why it is emphasized that thyroxine should be given at the time when patient has got empty stomach. It should not be given with any other drug. So I think make sure that patient is taking thyroxine that way. Then TSH polymorphism. This means that sometimes patient may have enough thyroxine, but because of some abnormality in the TSH receptors or TSH itself, and then TSH might stay high. So then we rely on T4. Deiodinase deficiency. This means patient has got, because I told you that in the peripheral part of the body, T4 is converted into T3, and T3 is metabolically more active. If somebody has deiodinase deficiency, he may have normal T4, but T3 may still be low, and patient may still have symptoms of hypothyroidism. So in these cases, you have to give some extra thyroxine. Then there's some other condition also where there could be refractory cases. So I think these should be left for the specialist. Now, prognosis, I used to say the prognosis in hypothyroidism is excellent, but I say now it is very good, but maybe slightly short of excellent. Now, excellent would be like if you become normal. Patient with hypothyroidism on thyroxine is close to normal, but not exactly normal. This is how I explain. In normal person, suppose this is the range, upper and the low range, and our thyroxine varies the level varies in the different times of the day, different level of physical mental activity, but the level of thyroxine is just right for that given condition, but for that given situation. But if we give thyroxine, then we produce a like flat level. So if you have a flat level, then at this point thyroxine is normal, but it is less than what should have been in a physiological state. So you are practically slightly hypothyroid here. In this situation, you have thyroxine in the body, which is normal, but it is slightly more than what should have been in a normal physiological state. So you are slightly hyperthyroid. So this may be little more perfection, but some people, they have this problem. So patient with hypothyroidism may still continue to have some symptoms. So the prognosis is very, very good, but maybe slightly short of excellent. Make simple and practical regimens. Now we have multiple strengths available. I think previously we just had 50 mcg, and we used to give one tablet daily or two tablets daily, or sometime two tablets and three tablets on alternate day. But now we have multiple strengths. We have 25 mcg, 50 mcg, 75 mcg, 100 mcg, and 125 mcg. Most patients will need just one or two pills. So after titration, if patient's dose is, for example, 125 mcg, just ask the patient to continue with one tablet of 125 mcg. Reducing number of pills is actually like improving compliance. Side effect of thyroxine, practically none, and the side effects will occur only if you give it an overdosage. So that is actually the iatrogenic problem. If you give in the right dose, patient should not have any side effects. In some cases, if it is overdose, patient may develop osteoporosis. And again, in overdose patient, you may develop exacerbation of ischemic heart disease and heart failure. And of course, we do not want these conditions because we monitor the patient and keep their thyroxine level within the normal range. Some additional abnormalities, dyslipidemia, hypertension, anemia. I told you most of these conditions will revert back to normal with thyroxine replacement itself. But at the end of first initial titration phase, a patient still has this dyslipidemia. Separate treatment for dyslipidemia and hypertension and anemia can be given. And these are, of course, separate topics, and we will cover them in separate lectures. So there's conditions called subclinical hypothyroidism, and these days we see quite a few patients of subclinical hypothyroidism. Even students need to know this condition. Now let me just briefly give you an account of subclinical hypothyroidism. When FT4 is normal, free thyroxine is within the normal range, and TSH is slightly high, more than upper normal. Some assays say upper normal is 4, some say upper is 5, but from upper normal to less than 10. If that is the case, we call it subclinical hypothyroidism. Now, as the name says, it is subclinical, you may not have any symptoms. Now, these patients are asymptomatic and no treatment is required, but you don't want to miss the possible hypothyroidism in the making, so you follow them up. That is the best approach, but treatment may be given, thyroxine may be started in some cases. And what are those cases? Opinion varies. I think most patients, they immediately, though many physicians, they immediately start with thyroxine. I tend to hold my temptation of starting thyroxine till I'm sure that this is actually hypothyroidism, not just a subclinical hypothyroidism. Some people with subclinical hypothyroidism will revert back to euthyroidism. Some will stay subclinical hypothyroid for their remaining life, and only few will develop hypothyroidism. And thyroxine may be given if patient is symptomatic. If patient is having symptoms of hypothyroidism, then even with borderline value, it is recommended to treat them because they have symptoms. And if they have hyperlipidemia, because then they are likely to develop ischemic heart disease. And if anti-TPO is positive. Now this, in my opinion, is the most important indicator because anti-TPO antibodies would not be present in normal healthy person. If anti-TPO antibodies are present, although patient is in subclinical state, but this indicates that the damage would be progressive and might as well start treatment right away rather than waiting. Then if there is a goiter, small goiter, I think that would also be an indication because with thyroxine, goiter probably will stop growing further. So summary points. This was a long lecture, but I have to cover the complete topic. And summary points. First, TSH and free T4 are the best tests for the diagnosis and monitoring. Subclinical hypothyroidism, wait and see until patient develops symptoms, or if one of those conditions I mentioned, especially anti-TPO antibodies are present, then you start treatment. Then different TSH levels and thyroxine dosage in pregnancy, and then low dose and slow escalation in elderly and those with underlying ischemic heart disease. There is no hurry. Take time, take 3 months, 4 months, 6 months to make them euthyroid. And lifelong therapy adjustment is needed in some situations like pregnancy, like trauma, like surgery, things like that. This brings us to the end of the second lecture on treatment of various types of hypothyroidism, primary hypothyroidism, secondary hypothyroidism, subclinical hypothyroidism, hypothyroidism in elderly, and hypothyroidism in pregnancy and other conditions. I hope this was useful, and I really look forward to see you in my in next video. And this is actually, I would end with this statement that hypothyroidism is one of the most treatable diseases. So I think intelligent handling is required. This is Professor Aziz-ur-Rehman from Medurstand. Thank you.